but we have this really bewildering system. And we have an age where data is now easier to come by than providers. I say again,
Yeah.
data is easier to come by. Objective data, whether it's labs or scans or other types of things, EKGs, et cetera, easier to come by than providers, which are in startlingly short supply and retiring every day.
Welcome to Success in Chaos, a healthcare podcast where each episode is dedicated to unlocking success amidst rapid change and uncertainty. I'm Angela Adams, the CEO at Inflo Health.
And I'm Kandice Garcia, the owner of Tungsten QI Partners and Quality Improvement Director for the ACR Learning Network.
We are so excited to have our guest today, Dr. Dan Durand, President and Chief Medical Officer of Prenuvo Medical Group. Dan is a physician executive and radiologist. Dan brings unique perspective on early detection, imaging innovation, and leadership at a time when healthcare is rapidly evolving. Dan, welcome to Success in Chaos.
Thanks, Angela, and thanks, Candice. It's great to be here.
Absolutely. So let's jump right in. We got to meet Dr. Durand at a Stanford Quality Conference and Summit and got to listen to a presentation by him. We learned a ton. First and foremost, I just wanted to ask you about your leadership journey. You've been in clinical care, radiology, innovation, executive roles. Tell us a few of those moments that kind of shaped your path towards where you are today as CMO of Prenuvo.
Sure. I think the first key pathway was probably the decision to come, where I wound up going to med school at Johns Hopkins and got exposed to a lot of really interesting perspectives, folks within radiology that are luminaries, who don't even need to be named, but folks like Stanley Siegelman, who used to run the residency program, folks like Jonathan Lewin, who was the chair at the time and went on to become CEO of MRI Healthcare, and just a ton of other folks. And I was also getting exposed to other investigators outside of radiology, people like the Vogelstein Lab, who are, for those who know, that they're the people behind the majority of the early detection so-called liquid biopsy tests. So there was a great interest there over the last 20 or 30 years in early detection, I would say throughout the medical school. And then the next key moment would be the decision to go into radiology. And why did I do that? I could tell you that it was because it was going to be the most data-rich specialty, and because I knew AI was coming. But that wasn't the way I actually made the decision. I wasn't smart enough to see that far in the future. I was smart enough when I was running around the wards to realize that, at least during the training period, which stretches out before you in medical school for the better part of a decade, I could tell that in most of the other specialties, I was going to be doing a lot of manual work and a lot of rework and restructuring of data. Things like, things we don't do anymore, but going and seeing what the labs are on the computer and writing them down on a piece of paper. And a lot of that just felt futile to me. And so when I was rotating at Hopkins, it was right when they were implementing PACS. And I saw these luminaries go from looking at what they call an alternator that had a lot of different CT films on it. They're actually reading CT on an alternator. People don't, not everybody realizes that used to be the case. And you can imagine the amount of mental kind of acuity it takes to follow those images across lots of images and reconstruct it entirely in your brain. I don't know that I would have been capable of that, but when I saw them sort of what we call drilling, scrolling through it, I kind of said, hey, this is extremely efficient. There were some really forward thinking people there around the structuring and unstructuring and surfacing of data to clinicians within radiology. The name John Eng comes to mind. He wrote a tool called RadAssist that extracted everything from the EHR that Hopkins had written so that radiologists, it would surface it and you could sort of see all the relevant parts of the history at once. So I looked at radiology and I didn't feel like it was siloed in that environment. I felt that it was connected to the rest of medicine and uniquely digital and really the first all virtual specialty. So the decision, to choose radiology was around the efficiency. And then later on, I was lucky enough that I think that panned out in a different way, right? Next key moment would be the decision not to remain on the traditional faculty path and join McKinsey. And, every time I get asked why I do that, I give a slightly different answer, which is very befitting of anyone who's worked for McKinsey. But I mean, it's basically, I knew I wanted to do something different. I wanted to be surrounded by a different type of people. And ultimately, what I was looking for was entrepreneurship. But at the time, I didn't know if I wanted to do that or policy or go back in academia with kind of leadership skills that you can only get at a McKinsey. Um, and, fast forward a bit, there were some other smaller decisions. The decision to go to a place called LifeBridge Health from Hopkins, where I had migrated back to after being part of a startup that went public. But ultimately, the decision again to leave academia a couple years later and to join a small health system executive team. And the reason I did it is I didn't want to wait. I felt like I was ready for certain types of decision making. And I also felt like a smaller, more nimble organization, even though it didn't have the global name of a Johns Hopkins, I felt like it was an extremely high quality place I could learn. And I personally learned by doing. So I wanted to be in the driver's seat and kind of making decisions at a service line level or a health system level. And then finally, after doing that for about a decade, the decision to come to Prenuvo to build, a health system based on prevention. That's the latest decision. And a lot of people think of us as a body scanning company, but I can tell you, I never would have come here if it was to just step back into radiology. I think the MRI scan is incredibly powerful. But what's even more powerful is the idea of gathering massive amounts of data proactively and using that to guide the patient through their health journey.
That's amazing. Thanks for going through that. I think a couple things I want to click on there. Candace and I talk about all the time. We love smaller community health organizations that are a little bit more nimble, a lot less red tape. You can be a doer there versus just, maybe have to deal with a lot of politics. So I love that you made that decision. And I'm sure it kind of escalated you towards your position today. But yeah, I am curious to learn. So from all of that background, you made the decision to go to Prenuvo. You kind of pointed out a lot of people think of it as the full body scan. There's a lot of opinions and emotions about it. But like what really kind of sparked your interest about Prenuvo? You've told us a lot about early detection, and I know that that's a passion of yours. It's a passion of mine. It's a passion of Candace's. So let's talk about that a little bit.
Yeah, well, everybody has, a professional and a personal story. So, professionally, that decade or so spent running accountable care organizations. If you look at how those organizations are judged, obviously they're supposed to control the total cost of care, but the work that you're supposed to do in order to achieve that, and in order to prove that you're improving the value of care without just stripping away care, is you're supposed to focus, much like Medicare Advantage plans do, on these quality metrics. And I would say the majority of them are population health metrics, many of which are population health screening metrics. So the only radiology metric of interest, at least when I began in the ACO program, was how many of the people who should be screened by mammography are. And I wrote a couple of papers on this sort of thing. And I was very focused on making sure these vast populations got screened. And what became very clear to me was screening means different things to many different people. That the mere act of screening doesn't necessarily guarantee you the outcomes. And that the way that we're screening as a society, while well intended, is sort of a byproduct of how we study things. And we study them at the NIH level in these organ system, well intended organ system stovepipes, I would say. And particularly in an age of AI where general intelligence may start to outweigh sort of detailed SME type intelligence. This idea that we're going to do this organ by organ and have a separate test and a separate set of consultation and shared decision making for each organ would lead to just a massive kind of circuitous nightmare of a system for patients. And everything I was trying to do in the ACO program, like hundreds of people, nothing unique about what I was doing, honestly, was trying to simplify it for patients. So what spoke to me about Prenuvo was the vision of doing this preventative way, non-invasively, without radiation, as comprehensively as possible, not to replace in its current iteration either primary care or any of the USPSTF tests, like mammography, colonoscopy, et cetera, but to think of a future where all that gets done or some subset of it gets done in a single setting, if possible, right? So to keep the patient with their agency and their sort of willingness to cooperate in the test. So the other thing is there's two personal stories. So one personal story is just thinking about the people in my life, right? If I think about the older people in my life who are Medicare aged, who are female, maybe who smoked, right? So if you think about what's recommended for those people is an annual CT scan of the chest, possibly a pap smear, depending on their provider. Very few of those, if any, are going to be vaccinated based on the years that program rolled out and the HPV vaccine. Certainly mammography, biannual or annual, depending on who you talk to. So again, recognizing there's variation. And according to the latest colonoscopy guidelines, an initial screening around age 45, and then sort of screening depending on findings and familial risk, or maybe genetic risk following that. So first of all, that's a lot of stuff, right? And it's a lot of separate appointments. If you've ever been through those things, all of them have a slightly different profile, right? And there are some people that say that embrace the mammography. There are some people that say, hey, I don't like the way that feels, or I'm scared of the radiation. There are some people like myself. So curiously, I've had, not as an asymptomatic person, but I've had a mammogram for something I don't feel the need to go into, but I had a lump essentially. So I can speak to this,
So you know how uncomfortable it is.
I know how uncomfortable it is. Yeah, I do. And I had mine after I had a biopsy. So, really, well, I was numbed up. So maybe that actually made it easier. Who knows?
Okay. Yeah, it's not a comfortable
I have some sense. I have some sense of that.
Got it.
And again, I would never tell anyone not to get it, but having run these programs where you see anywhere from 20 to 40% of people not participating, you can sort of convince yourself that they're all ignorant or non-compliant or whatever, but in fact, they certainly have a point together, right? If this was a really consumer-friendly test, we wouldn't see that profile, I don't think. And colonoscopy, I actually went, even though it's in my family, even though I know people who have passed away from it in their 30s, my sister-in-law, it still took me about a year before I sort of had the time and the guts to go under sedation, which is something I don't like to do. I have a busy life. If you've done the colonoscopy the right way, it's a couple day process actually, right? And for me to know I was going to be in the same city and to know I'd be sort of in the right headspace and then do the whole prep, I didn't get that done until about 4 months after my 46th birthday. And I was personally able to get, obviously based on, who I am, like I was able to get in for 2 Prenuvo scans before then. But again, like there are some people that are more claustrophobic and maybe like sedation or don't have a problem with it. They might have a different profile. The point is all these tests have something. They all have a something that could drive people from getting them. It's important to have multiple options, but I think it's also important to have the principle of, can we have a place that people get lots of these things done? And that's what my hope is, that Prenuvo becomes over time an access point where you can get almost anything done that would be of relevance to prevention, because these tests, with the exception maybe of colonoscopy, right? Because that's a fantastic test in that you can intervene in what you find. But many of these tests, they're getting closer and closer to sort of a single blood draw or at least a single blood draw option or a point of care option. And I do think that a lot of them can come to the ambulatory environment and be done in a single access point.
What I think is so interesting here is, I think we had talked about this when we met, is that this is not just offering an MRI. This is not just actually even offering preventative services. This is really changing the way that we think and engage with not only our medical system, but our best practices and population health. I'm really feeling the challenge of operationalizing the way that we interact with healthcare, the way that we interact with our own care. I know there's desire for it. The barrier to getting information from a healthcare system is so high. Getting a primary care appointment, somebody placing an order, and then you get a mammogram, like you said, you get a colonoscopy, and you're like, but what about everything else? So the barrier to getting the information is high. And then, like you're saying, right now, those are the only options. Those are the only options for information. And if we even just switched what was available, I'm feeling, and I think you mentioned this, that there is just even the shift of thinking in a new way, that preventative care can be delivered in a new way, that we can take all of these things, we can rethink the way that we understand prevention and early detection. Tell me a little bit about some of the challenges with how you're you're kind of bringing these two worlds together. Is there an acceptance from, the reactive medicine? And how are you fitting proactive medicine into that ecosystem?
There is increasingly, in fact, acceptance that I see. And one of the reasons you know this is put Prenuvo to the side for a second. At least two major academic medical centers have begun full scale, publicly displayed executive health programs in the last few months. And whole body MRI is in there, but it's not the only thing they do. And the two I'm thinking about are Jefferson Health in Philadelphia and Cornell Medicine in New York. You can go online, you can see what they're doing. I guess technically they're competitors. So here I am. I don't care. I think it's good to have company, especially from great places. And the people I know from those places are fantastic. So
Competition too, it validates the market.
it
So
does. It validates the market and it shows that there's something to this.
that's great.
I think the perspective of traditional medicine comes from a time when providers were easier to come by and data was harder to come by. And the construct that's been perpetuated around this um, is seen through the lens, I think, of the finances of healthcare, the government, the payers, people who, for really good reason, have to think about a scarcity mindset until they don't, right? So those same people, let's just rewind a few years, and they told us that urgent care was going to sort of be a huge disaster. And now it's really one of the only things holding the healthcare system together. And almost every AMC plays in it and has training programs that point toward it, right? If they don't have a specific training program. Another thing was telehealth. I would say, well-known radiologist, Pat Bowsey, was the first CMO of Doctor on Demand. Doctor on Demand was one of the very early, if not the early direct-to-consumer telehealth play. I think they had a partnership with Dr. Phil. They were on the TV. This is about 10 to 15 years ago. And people gave them a hard time about overutilization. You're going to overdiagnose people until COVID happened and everybody suddenly realized about the
Needed it.
amazing that this does for access. And the providers then realize, many of them, hey, as much of my time that I can spend in this modality, I want to. Because at the same time, I would say the advancement of all sorts of testing, even pre-AI, for my generation, was getting people to think more about the richness of objective data and also how limited the physical exam is, which then for the earlier stages of acuity makes you wonder what encounters you need to do in person, which you don't need to do in person. And the provider access crisis multiplies this and makes the business people and the health system and the policy people think about it. So let's just bring that back to today. As you referenced, if you are someone and you're trying to figure out where your health is, the health system plus our knowledge of disease, it's kind of like a gigantic, very in-depth map that exists, right? And you don't know where you are within it. So you're kind of like me back in the early 90s on a family vacation with a Rand McNally atlas. Great atlas, nothing against Rand McNally, binder of pages, right? But the thing is, they can't tell you because it was printed months or years earlier what's going on that day or where you are. For that, you need GPS. You need everyone to have a supercomputer, cell phone in your pocket. You need communities and apps to exist so that people get real-time information, all of which we take for granted today. Because the data became more ubiquitous and the standards for sharing it supported it. And it was consumerism and the iPhone store and that device, that particular device, the phone, right? The iPhone and other types of smartphones that drove that. I think you're going to see that in healthcare. I think that's happening. I'm not sure if it's being driven by the technology, to be honest with you, or the access crisis. But we have this really bewildering system, and we have an age where data is now easier to come by than providers. I say that again. Data is easier to come by. Objective data, whether it's labs or scans or other types of things, EKGs, et cetera, easier to come by than providers, which are in startlingly short supply and retiring every day. And that is not my fault. That's not your fault. There's a lot I think it was a societal mistake, but it's where we are, right? And the only way I think a lot of people feel, whether it's honestly reactive or proactive care, to fill that gap is to get better and more data, layer in some kind of decision-making apparatus, whether it's AI or extenders or a combination of the two, and reserve the physician firepower, for the end, for the sort of highest point in the licensed pyramid.
Yeah, I could not agree more. The shortage for healthcare workers is not ending anytime soon. We keep saying like the cavalry is not coming. Nobody's coming. Like we have to redesign the way that we interact with each other and the way that we interact with information to do this. Can I ask you a little bit about your leadership? Because I know you're a leader in your organization, but you're leading like a thought transformation and an operational transformation, a real like perception and in the way that we, understand medicine. How do you like actually go about doing this? What does that take
Yeah,
to
I feel like
get
I'm in
an
the third,
entire yeah.
I feel like I'm in the third phase of my career from a leadership style perspective. And in the first phase, I was sort of working these different entrepreneurial jobs and doing a lot of, conventional thought leadership, putting stuff out there. And the second phase, I was busy enough that I didn't have time for that anymore, but I still kind of posted a lot. I would say I'm at the phase right now where outside of these conversations, I'm mostly trying to get my point across by through what I built and through what we built. I would say, I'm trying to build up teams that create amazing things. So it really is a question of just sort of seeing the vision, getting in with the right organization. It takes a while, but sort of getting to an equilibrium amongst the leaders of an organization and the market as to what you're going to do and what you're going to, and knowing that the right market's ready for it and that you're capable of bringing it. And then it's, getting the right people to deliver it and staying out of their way, and I think I'm good at the latter part, that sort of seems to be, I think I'm reasonable at picking people, but I think what I'm really good at is letting people, creating career paths, even with to pivot them to get people to bring their most distinctive contribution to the firm, to Prenuvo.
That's amazing. I think it's always the hardest to be the first. Prenuvo, just like you said, urgent. We could name 10 different things in medicine that were laughed at and said, this will never work, and that are core of our health system today. So I think Prenuvo is visionary in what they're doing, but I always tell people, the hardest person to be in the room is the first. The easiest person to be in the room is the critic, because it's so easy to criticize what somebody else is doing. I would say that most people I talk to about Prenuvo, they all wanna go get a scan. So what does that tell you? Like, I don't really care what
Yeah.
other people in medicine that are just, like, criticizing it are saying. I'm, like, curious about the consumers around me, and the consumers around me, whether they're from healthcare, not from healthcare, know nothing about healthcare, they all wanna go get a Prenuvo scan because we all wanna know what's going on inside of our body. And to your point, like, consolidating all of these different kind of tests into, I could go for one visit as a busy professional, I could go for one visit and get answers to lots of my questions, is amazing. You have people like flying to Dubai. I mean, not right this second, but flying to Dubai to like spend 3 days doing, like, full body everything, and it's so interesting to me that the medical community is still arguing that, like, "No, this is not the right path," and the consumers are very clearly telling them, like, "You might not think it's the right path, but this is the path we're gonna go down, whether it's in the United States or outside of the United States. Like, we're gonna go fly, spend thousands of dollars to go get the type of medicine that we want, which is preventative medicine. Some people call it wellness and longevity medicine. Some people call it functional medicine. But like, I know for a fact I use it. Like, I want to know how to prevent things. I don't want to wait until somebody tells me, like, oh, you have diabetes and now you have to take medication for the rest of your life. Like, I want to prevent all of those things from occurring. And I feel like the consumers are certainly at a place where they want that as well.
Yeah, I think this is a generation that believes that information is power. I mean, you just kind of look at the way the world has changed. It has democratized the world in some ways. It's this business about the information economy, not specific to Prenuvo. Always within it, there's this question about equity, and it's an important question to deal with up front. So you referenced that there are many models where people need to fly to do this, and in some parts of the world, there are price tags that are many multiples of what we offer. We view ourselves in the continuum of this as really one of the greatest democratizing forces that are bringing this out. There are other people that do similar things, sometimes for less money, and all I can say is we are constantly trying to make sure that we balance the quality around what we're trying to do with market access, and we're also conducting studies. We're conducting a massive health equity study in the Boston market called Project Hercules, where we are subsidizing a significant portion
Wow.
of the exam costs for those that qualify. And those efforts will continue. We also have a consumer program that's not a study, although there are some separate studies that are similar going on where we offer a discount to first responders and firefighters who, the tip of the iceberg was the signal, the initial signal within the 9/11 cohort that had a high cancer risk. It was later discovered that this is a broad risk shared amongst almost all firefighter populations. And then also many other veteran populations, particularly if they were near things called burn pits, which were used to dispose of waste in certain parts of the world, during various conflicts in the 20th and 21st century. Equity is an important part of it, and it's in our crosshairs as a big thing that we need to continue to um, value, right, and think through. You can't advance anything in a direct to consumer market without having some threshold of if someone can afford it or not, because ultimately they will be paying for it personally. But the other thing that does that people don't think about is when you remove a third party payer from an equation. And so this office that I'm pretending to stand in, I mean, we have this great relationship that occurs here. It's a med spa type environment people like to be in. It's all about the patient. They are only our one and only customer. If we cease to delight patients, we cease to exist very shortly afterwards. There is nothing currently in our whole mindset that is modeled towards prior authorization or these other things that are now being, I think, rightly vilified throughout society. We don't have any of that. And that creates this great bond and focus on what matters to people, what matters to patients, consumers. We don't always think of them as patients. They come in healthy, they come in charge. We call them consumers. It's not so much or members. This isn't like an economic type thing. It's actually about agency. I think of someone more as a patient when they're a little more vulnerable. Honestly,
No, that's incredible. I love what you guys are doing. As a wrap-up question, you had told us that, I mean, you guys are also doing a ton of academic research and putting a lot of information and data that has not been previously available in the hands of researchers. Talk a little bit about that because I think that's a really amazing thing that's happening that you guys have spent a good amount of time and put a lot of priority on.
yes, we've done somewhere between 150,000 and 200,000 whole body scans. Every one of those scans has been reviewed in an extremely structured way using something that is akin to like a home inspection list for the human body. So I think it's the most comprehensive and largest structural report in radiology. And we have pretty soon we'll have 200,000 of those to go along with really, really great images. And then also we have a medical intake form that we have on a subset of these patients. So for those in whom we have the appropriate permissions, we have a massive data set of over 100,000. We've already used it to produce something on the order of 40 or 50 abstracts. Don't quote me. I think 5 or so peer-reviewed articles with a lot of other ones in press, at least one of which it was in a Nature one of the Nature publications, not the Nature, but one of the Nature publications, and somewhere between 20 and 30 active university relationships. Our longest standing, highest yield relationship has been with Dr. Cyrus Raji, who is a neuroradiologist at the University of Washington in St. Louis. He is a visionary and pioneer, and I think the person when it comes to sort of global whole body impact on brain health specifically.
Mm.
With him, we've done a ton of research. We've been able to validate findings and hypotheses about how different parts of body composition and general health relate to neural health. And been able to find new things that were unexpected. So an example of this is during this year's RSNA, I think the most widely cited paper by the press was a paper that was based on our data set showing that increased muscle mass and decreased visceral fat independently both predict long-term cerebral volumes, which correlates is a well accepted metric for long-term cerebral function, essentially long-term cognitive function, Isn't guaranteed when you maintain brain volumes, but it is, kind of, it is necessary, but not necessarily sufficient. But this is a big result when you can prove it over so um, many people, and particularly relevant today when you have a lot of people like myself. Actually, I'm one of these people. I'm electively on a GLP specifically for my visceral fat and my overall familial risk of dementia. Not something that you could see without an MRI in me, but something that is higher than it should be. And the decision to go after visceral fat, which is pretty tough to do, honestly, without a GLP, because there's not a lot of ways you can target it without massive reduction of fat that I'm aware of. Um, Also carries with it risk of losing muscle mass, right? So you have to balance these things actually. And as we get into these more nuanced therapeutic areas and asymptomatic individuals, studies like this are really important for people to understand what they're getting themselves into. Right. So I have elected to sort of do a low dose approach and like really focus on protein intake and maintaining muscle mass. By the way, this result doesn't mean that if you go on like growth hormone and get huge, you're going to be the smartest person. I mean, I think that goes to that more about mitigating risk, right? Um, but
Oh, because I
that's,
had already ordered it. I had already ordered
Yeah.
I'm sure someone's out there trying that, but that's not what the result means. But for me personally, I'm just kind of, I'm one person, I'm illustrating it, but that is, there's a massive interest in body composition and metabolic health right now
Mhm.
because of new things we can do. And both conventionally with, I would say GLP is now fairly conventional. And then you have the sort of unconventional, the peptides and other. So I think that our publications and the types of data we're putting out there are eye-opening and interesting. And if there are investigators listening to this, what I want to do is increasingly take this data and put it in the hands of the brightest people, which, candidly aren't necessarily me or the people who work at Prenuvo. It's the people who work at the AMCs and maybe other types of organizations. So we have 28, or I think 28 was the last thing I heard, university collaborations ongoing. And what I want is for us to have 100. I want us to be sort of almost like a UK biobank type approach for whole body MRI.
You heard it here, guys. Call call for researchers. No, that's amazing. Well, as we wrap up, we always like to, our audience is mostly health system executives and even technology leaders and quality folks. So we always like to ask you, like, what's something that you've read, a book, a podcast, like, give us something that has really given you an aha moment.
Yeah, right now, in 2026, I would say that my aha moment hasn't been from a book, and it hasn't been from a single podcast. It's been with patients that I've spoken to who are using the new AI capabilities that are directed at healthcare. So specifically after JP Morgan, a number of my connections, they went and tried for themselves the medical versions of Claude and ChatGPT.
I have as
And
well.
they got really, really interesting results, right? And all of this comes with a disclaimer that these companies give, which is appropriate. This is not medical advice. But these are doctors themselves, most of them, or people deep in healthcare. And they uploaded all their medical stuff, or a huge portion of it, and saw what it spit back. The other thing that was going on at the same time from 2025 is Eric Topol wrote, okay, here's the written piece of this. There was a well-cited New York Times article, or Wall Street Journal, I forget. Eric Topol and Dr. Rajbukar up at Harvard, who's a very famous AI. And what they had been finding is that for the first time ever, these past few months to years, if you look at AI by itself, it actually outperforms AI plus human, which outperforms human by itself. Very controversial result, really hard to validate and prove, but it's sort of out there as many people are endorsing this. And when you look at those things, one of the criticisms of the AI algorithm that was outperforming in these various diagnostic tests, standardized tests that they've created, is it's fairly resource intensive. Uh, so that was in the back of my mind. And when I drilled down on that, it was something about it actually ordered more scans, which I thought was interesting. The folks that are sending their stuff to these AI algorithms today also came back and they said, it doesn't really care about 90% of the stuff I give it. Like, it doesn't care about the EHR note. It really focuses on the objective data. It doesn't care too much about what the doctors say. I mean, it really wants to decide on its own, and it wants to ask for more of that type of data. And I found it fascinating. I think that in 2026, what I'm thinking about is that people are hungry for AI, and AI is hungry for data. So people are going to be even hungrier for data about themselves, about things they don't know, about things they could know. So I don't think it's new news, right? We've been saying this forever, but like it actually could go to a different level. There was this last thing I'll say. I used to have a presentation where I quoted the idea that all of like 50% of all health and human data was collected in the last 18 months. There was almost like this like Moore's law, or maybe it was 24 months, but there was this thing where like you could go from the beginning of human history all the way up to 2019, and there was X amount of data. And that same amount of data would have been gathered in 2020 and 2021. Right. So it's
Yeah.
like
It's
really
insane.
understand like how now I got to think that that's going to be even more pronounced. It's going to be like every year the data doubles.
Yeah.
And the providers stay the same, per capita going down. Like, it all leads us back to the same place, right? It's like the more you move toward it, right, the more the goal of having all the data synthesized moves away unless you embrace some other model, whether it's organic intelligence that's not a physician, like an extender, or artificial intelligence.
We can do a whole podcast just on those closing remarks. So thank you so much for being on, Dr. Durand. What a good time that we've had. And thank you for answering all of our questions. Candice, do you want to?
Yeah, I'll take us out. So thank you, Dr. Duran, and thank you, audience, for joining us on Success in Chaos. Please be sure to like, follow, and share today's episode on Spotify, Apple Podcasts, YouTube, or wherever you get your podcasts. And a special thank you to the Inflo Health team for their production support.